Good morning and good afternoon, everyone. Today, we're really happy to have you today on our discussion addressing the COVID-19 crisis, an open forum webinar series for pharmacy. My name is Sandra Leal, and I am the Executive Vice President for Symphonia RX, a TRHC company, and President of the American Pharmacists Association. And I'll be the host and moderator for today's discussion. Today, we're going to focus on talking about issues around COVID-19. So we will be talking about the evidence and recommendations related to COVID-19 disease and its impacts on pregnancy, breastfeeding, and those contemplating pregnancy. This webinar is conducted in collaboration with the American College of Obstetricians and Gynecologists, ACOG. And we have some really great speakers today to have a really good dialogue about questions that you're probably seeing out in practice today. Next slide, please. Today we have two wonderful speakers that will be joining us. We have Dr. Jen Via Vicenzo. She serves as a Darney Landy Fellow at ACOG with the Strategies for Health Equity team. She is a Cuban American who was born in Miami, Florida, and is the daughter of an immigrant and a nurse. She is an expert in OBGYN and complex family planning, health policy, and strategic communications of socially complex subjects. In addition to clinical caregiving, her passions include reproductive justice-informed health policy and health equity. We also have with us today Dr. Veronica Vernon. She is an assistant professor at Butler University, where she teaches women's health topics to student pharmacists and physician's assistants. She is board certified in pharmacotherapy and ambulatory care, in addition to being a North American Menopause Society certified menopause practitioner. Dr. Vernon created her own position as a women's health pharmacist at the Indianapolis VA after completing 2 years of residency and has assisted several VA medical centers in expanding the role of pharmacists to include women's health services. We also have our subject matter experts for Q&A that will be joining us today. We have Mitch Rothfuss, who's the Chief of Governance and State Affiliates for the American Pharmacists Association, and he is also the Executive Director for the American Pharmacists Association Foundation. He is our internal vaccine expert who has joined us for many weeks on this discussion. We also have with us Dan Slott, who's our Senior Vice President for Education and Business Development for the American Pharmacists Association. Dan comes with 10 years of experience at the NIH as an oncology infectious disease specialist. And we also have with us today Elisa Bernstein. She's the SVP for Pharmacy Practice and Government Affairs at APHA and brings 30 years of experience with the FDA. So let's review today's format for the webinar. We will have the discussion with Dr. Jen Via Vicenzo and Dr. Veronica Vernon from about 1:05 to 1:25. And then at 1:25, we will go into an open forum discussion to have your thoughts heard and answer your questions. At 1:50, we will review an ongoing with relations to APHA and what's coming up. So really exciting information to share with you about the organization. Next slide, please. So just to remind you about open forum ground rules, if you have any questions or any thoughts, please go to the field, the questions field on the GoToWebinar toolbar to submit those questions to have any of your discussions addressed or any questions answered. We will try to answer as many questions and comments as possible. And we also have the handout in the toolbar for today's slides with the links to resources that will be available to you after this discussion. This webinar will be recorded and it will be available after 24 hours for you to review. So with that, I will invite both Jen and Veronica to join me on screen here. Thank you so much for joining us today. Really excited about this topic that we're speaking of because we've seen so many questions related to COVID-19 and women's health and pregnancy. So I'll start with you, Jen. Can you tell us a little bit about yourself and your work with COVID-19?
Absolutely. Thank you so much for having me. I'm coming in speaking with you from my clinic, so excuse the scrubs, but this is kind of the real world of actually COVID-19 care. I am an OBGYN, as you mentioned, and a family planning specialist, and I've been practicing throughout the pandemic, offering the full breadth of obstetrics and gynecology care. And I was in particular in Ann Arbor, Michigan in March when the pandemic really kind of kicked up in the United States, and when Detroit was one of the hottest cities in terms of growing cases. And so I had a front row seat to not only what that looked like in the federal and local coordination around the pandemic, but also the fear and concern around not having the data and being a provider and taking care of pregnant people and breastfeeding people and helping them understand. And so I'm really glad to see how far we've come. You'll hear from me a lot that we have a long way to go and a lot of data that we still need to collect. But ultimately, we really know a lot more than we did last year. And so I'm happy to be with you, and thank you for having me.
Well, thank you. Thanks for all the work that you're doing. I know it's been busy out there, and I appreciate you taking time to join us this morning. Veronica, can you please tell the audience about your practice and your focus on women's health?
Yes, thanks for having me. I am an assistant professor at Butler University where I teach our student pharmacists and our PA students about women's health. And I also maintain a practice at the VAs on a limited capacity, but still enjoy working with our female veterans as well as some limited male veterans. And I have predominantly done some work on our state level related to the COVID-19 vaccine rollout in Indiana and getting messaging out about vaccine hesitancy and dispelling common myths among the general Hoosier population here in Indiana.
Well, thank you. You both sound like you're very, very busy doing really good work out there. So again, thank you for joining us this morning. Well, let's jump in and let's talk. Let's go with Jen here. What is the latest evidence and the impact that COVID-19 is having on pregnant individuals and individuals that are breastfeeding?
So over the last year, we have found from the data that multiple national organizations as well as global organizations are collecting that COVID-19 infection is of particular risk in pregnancy. Initially, we weren't sure if that was the case. Those of us who practice obstetrics know that pregnant individuals and postpartum individuals, for example, are at high risk when they get the seasonal flu. And so we were wondering if that was going to be a similar situation. It didn't really pan out in the first couple of months, but then we realized that there is definitely from the data showing an increased risk of more severe illness compared with non-pregnant peers. And so what that means is in terms of severe illness, it means that a pregnant person who has COVID-19 is more likely to have an ICU admission, more likely to need mechanical ventilation or need to be intubated. They have a higher risk of needing ECMO, which is a very specialized form of mechanical ventilation, and they do have a higher risk of death. And so the CDC, because of this data, has put pregnancy in a higher risk category for COVID-19, along with some of the other high risk categories like older age that have become well known in the public.
Yeah, lots of issues to contend with, and since this is new, we're getting information breaking, it seems like, on a daily basis. So definitely see that. Let's go with this next question. So what is the current ACOG guidance for healthcare providers related to pregnant patients with receipt of the COVID-19 vaccine?
So as I mentioned, it was really scary as a provider, as a pregnant person at the beginning of the pandemic, because we didn't have the data, we didn't know what was going on, and we didn't have any way other than the masking, quarantining, and social distancing to protect pregnant individuals from getting COVID-19. And so as soon as the vaccine came out, ACOG, the American College of Obstetricians and Gynecologists, knew that we wanted to really dig into whatever data they had and look at how this vaccine could help pregnant and breastfeeding people. The problem is, which is the problem with a lot of clinical trials, most of them in fact, is that they don't include pregnant and breastfeeding individuals. And so ACOG has persistently advocated that trials include pregnant people so that we can make sure that their unique physiology and their unique biology that's going on during that natural state of being of pregnant and being postpartum is studied. So at the beginning, we didn't know. However, we do have great data and great science about what these vaccines, in particular Pfizer and Moderna, the mRNA vaccines, what their bioplausibility is. It's a big word for like, how do they work and how could they potentially impact the physiology that we understand about pregnancy. And so we felt pretty comfortable saying that while there was no data, it was unlikely that these vaccines were going to negatively impact pregnant individuals. And we weighed that with the risks that we already knew existed with COVID-19 in pregnancy. And with pregnancy and postpartum period, that's always what you're doing, is you're weighing the risks of two things and which are you more worried about. We encouraged individuals to talk to their providers and make individualized decisions for their families. If they were frontline workers who had to go out all the time and they were pregnant, they may be more inclined to get a vaccine that doesn't have pregnancy data rather than someone who is able to stay from home, work from home, and ride it out a little bit longer until we get a little bit more data. And so ACOG's guidance was that we did not want pregnant individuals to be refused on the basis of pregnancy for their vaccine. And that has remained our consistent guideline, is that we want people who are pregnant, breastfeeding, and postpartum who want the vaccine to be able to get the vaccine.
Great, thank you. And Veronica, what are you hearing from the pharmacy community? What kind of concerns are coming up? And what can you share around the safety of the vaccine to give pharmacists confidence as they're counseling patients?
I think to tag off what Jen said is I'm hearing a lot from pharmacists about, is this safe? I don't want to make a wrong recommendation to my patients, but I think we just have to look at face value what we have, and we have to be completely transparent with our patients when we're talking to them. This is what we know, this is what we don't know, and help them weigh the risks versus benefits. I think Jen does a great job talking about this, but this has to be a patient-centered conversation, and the patient has to be the ultimate decision maker. And I feel with each day that passes more confident about the safety of these vaccines in our pregnant and lactating patients with more and more data that's getting published. We just talked about, there was an article published 21 hours ago in the New England Journal of Medicine. And so this is good news for us in the healthcare community that each day we are getting more and more information. But I know for most pharmacists, it can be hard to keep up to date with all of this. So that's why attending this webinar is a great idea, using your network and finding those primary sources, because what we're seeing from patients that we're going to talk about later is there's a lot of misinformation and myths that are spread like wildfire about the vaccine. And we have to be entrusted to stop those myths and to give the most proper and complete information.
Absolutely. And I appreciate that you brought up that article, because I was reading about it this morning. I'm like, oh my gosh, we have a webinar today. I better catch up on this. Any highlights from that you wanted to point out from either of you, Jen or Veronica? Because I know the information that was published is very positive in a way that hopefully gives people ease about the confidence with this vaccine. So anything that you want to highlight from that?
I think that's exactly it. The headline is, we continue to get more data. We have tens of thousands of individuals who have said that they are pregnant and got the vaccine and are doing well. We also have a very well-run study, which I think we'll talk about on the next slide. It's called VSafe, where we've enrolled almost 5,000 people who are confirmed pregnant, and their outcomes have been similar to that of the general population, which implies and demonstrates through empirical evidence that the vaccine is, as far as we can tell with the data that we have, not impacting pregnancy negatively. The caveat to that I think is important for people to know is that pregnancy is a long course of time, right? You've got your 9 to 10 months of pregnancy, and then you have in the way ACOG views it, year-long postpartum period. And so that's a lot of time. We certainly have not had that period of time where the vaccines have even existed. And so we need to continue collecting data. We need to continue monitoring this, but all of the signs are pointing to that this is very safe, and it is in fact helping protect people, particularly people who are at higher risk, like breastfeeding and pregnant people, from getting COVID-19.
And I have a couple of questions. So we've been collecting questions from previous webinars that people have posted around this. So I just want to make sure I address some of these, and these are some of the ones that we're seeing in the comment area too. But just a very quick question. Do patients need clearance from their doctor to get a vaccine? Any thoughts on that, Jen?
No, they absolutely do not whatsoever. That is, and that's not to shame anyone who has thought that they did. That is a common myth, as Veronica was talking about. There are a couple of those out there. I'm representing ACOG. You can feel very confident that you do not need any sort of permission from a doctor to administer a COVID-19 vaccine to a person who is either seeking pregnancy, currently pregnant, or breastfeeding. We know that as far as the data is telling us that it's safe, and people are getting vaccinated all over. And so if they want that vaccine, please stick it in their arm, give it to them.
Perfect. And then the other questions that have been coming up a lot have been around future pregnancy in younger populations, teenage girls, anything that that you want to discuss with that? I'll start with you, Veronica. Anything that you're hearing around that, concerns about future pregnancy, safety of mRNA vaccines that you want to address?
Definitely. This question came up at our own campus clinic we had at Butler just last week or a couple weeks ago. And so there was a myth put out on social media that spread like wildfire that the mRNA vaccines are going to lead to infertility. And this was started because someone said, well, the spike protein that your body is going to make against the SARS-CoV-2 virus looks just like syncytin 1, which is on placenta. And that's where the infertility debate has come from, saying that we're going to create antibodies against placenta and that's going to lead to infertility. There's no truth to that at all. It's a complete myth. If you look at the syncytin 1 data from looking at some of the scientists that are leading in this field, that protein is much smaller. It's half the size of what we see in the antibody for the SARS-CoV-2 virus. So it's a different key and a different lock type situation. And so it's our role as pharmacists and as healthcare providers to dispel this myth that there is no merit to those conversations. Yes, these vaccines are approved under an EUA and we don't have long-term data, but I can feel confident saying that it's not going to impact fertility based on what we know now, because the proposed mechanism that's been out there has no scientific basis at all. And I'll let Jen add on to that.
Yes, Jen, if you have anything more to add, that would be.
Yeah, I think you explained that beautifully. Basically, the theory behind how this could impact fertility is not a sound theory. And so it's understandable why people would be concerned about this. There was a lot of anti-science, a lot of pseudoscience sort of going around, especially the mRNA and what it does to your DNA, and it's changing people's DNA. So there's a lot of concern in the general public, which I think is understandable, and we need to address that with people. But ultimately, there is no bioplausible reason why this would cause infertility. There's no theoretical reason why this would cause infertility. And certainly, and as far as we can see, based on the data that we have, it's not causing infertility. ACOG is being very careful about making sure that we continue to look at the data and ensure that we're not ignoring a possibility and wanting to really look at the data closely. But we have not seen anything that suggests that that's the case. And again, getting sick with COVID-19 can lead to really significant impacts if you have severe disease, which may impact your health later on, right? And we've been seeing reports of that as well. And so I think it's really important for folks to think about their health now and their health in the future, and how protecting themselves from COVID-19 with the vaccine, as well as all the other measures that we've been talking about, can help them in their family planning in the future.
Great. Well, thank you so much. I think you hit some of the points that have been coming up quite a bit, that have been getting a lot of traction. And I know we're working as myth busters along with the vaccinators. But let's go into that study that you were talking about earlier, Jen, the one related to the VSafe pregnancy registry data, and see if we can share some information about how many pregnant women have received the vaccine. Hopefully that shows people out there that we are getting more and more evidence every day.
There are sort of two ways in which you may see the data around pregnancy and vaccine being reported. Or two numbers. There's close to 100,000 people who have gotten the vaccine that say they are pregnant. And so there's a significant amount of people that have gotten the vaccine and say that they're pregnant. Then there is this very tightly controlled CDC VSafe pregnancy registry data, which is people who are confirmed that they are pregnant. And so one is a little bit looser in terms of, like, if you say you're pregnant, we put you on the list. This one is a registry for people who are confirmed to be pregnant. And so this includes about 5,000 people as of April 19th, so a couple of days ago, so it'll be a little bit more than this now. And as I mentioned previously, this is really important. I saw, I think, a question in the chat about people with prior pregnancy complications and things like that. These are all comers, so they're not necessarily seeking out people who have had prior pregnancy complications, but certainly if you had one, you can enroll if you've gotten the vaccine. And so the data collected through this registry is indicating that essentially people who get the vaccine who are pregnant are reacting exactly the same way as people who are getting the vaccine who are not pregnant. So you might feel a little crummy after you get the vaccine and some arm soreness. That's what pregnant people are saying they're feeling as well. And it did not indicate any safety concerns. And in terms of the people who have completed their pregnancies, there has not been any increased risk beyond baseline risk for the general population in this cohort of individuals that got the vaccine. And that's a really important point that I just want to reiterate, is that you may see, particularly in the paper that came out recently, well, here are the number of complications that happened in this cohort. We have to compare that to the baseline complication of the general population, because being pregnant, there is a risk of complications, period, end of story, regardless of where you are. And so we want to compare those two rather than just looking at it and saying, oh man, 1% of people had a stillbirth with the vaccine. That is comparable with the general population.
That's great. No, you make some great points there. And I wanted to answer another question that's here. Maybe Veronica, you can take this one, around recommending one vaccine over the other in pregnancy, breastfeeding, or those seeking pregnancy. Is there a preference of one vaccine over the other?
What I tell patients is what's available to you. Take that vaccine. I can speak from my personal experience. I was pregnant during the pandemic, right at the start of the pandemic. I was newly pregnant and I delivered in October of 2020 and had a healthy baby boy. But I was one of those patients working with my OBGYN, and we were nervous at the start of the pandemic. I was in my first trimester. What does that mean? What does this look like? And I received the Pfizer vaccine in January as I was going back to work, as that was what was offered to me as a healthcare worker when I was going back into clinic. And I was exclusively breastfeeding at that time and still am. My son was 8 weeks old when I received the vaccine, and we did not have any issues. I hear from patients concerns about how will this impact my milk supply? How will this impact baby? My son did just great. He wasn't fussy at all. I had pretty limited effects. I joked with my husband, who is a physician, that I think he had worse effects from the Pfizer vaccine than I did, because I was just tired from taking care of a newborn, as was he, but more so I was. And I think he definitely had more severe effects than I did, because I just chalked it up to being sleep deprived. But I think the vaccine that's available to you is the bottom line. That's the one that you should get. There's no recommendation currently based on what we know today that there's a preference for one vaccine over another in patients who are trying to conceive, who are pregnant, or who are breastfeeding.
Great. Well, thank you for sharing your experience. And I've seen your baby picture, so cute little boy.
And just a shout out for breastfeeding and the vaccine. There's some data to suggest that your kiddo got some of that immunity, which is a major plus, because babies can't be vaccinated right now. And so go to work on passing that immunity.
Yeah, that's great.
You.
I actually was reading a story about a pregnant woman that got vaccinated that had some protection and antibodies in the child. So we're starting to see more data on that. That's great information to share. And the last couple of weeks we've talked a lot about J&J and the safety around clotting. Do you have any concerns around the J&J, especially as it relates to women using oral contraceptives? I'll start with you. Let's see, Jen. We'll pick you.
So this is obviously very new and breaking information around the Johnson & Johnson vaccine. I think that we have to trust in the FDA in terms of the pause that they've put on it. I think it's also important to quantify the risk that we're talking about, which is 6 individuals and over 7 million. That's not to negate the possible severity of that, but it certainly is not happening in a large proportion of people who got Johnson & Johnson. Additionally, based on the data that we know, which is still somewhat sparse because it's new, the clotting syndrome that exists around in Johnson & Johnson is vastly different than the clotting syndrome that might occur rarely with combined hormonal contraception users, right? And so the only similarity is the fact that the word clot is in both of the two names. The entire cascade and the way in which that happens on the molecular level is quite different as far as we know. And so there is no indication that we know of that could suggest that there would be an interaction. We certainly are not at this point recommending that people stop their oral contraceptives or not start them, but definitely we're waiting to get more data to understand it. As of right now, the Johnson & Johnson vaccine is paused because of this. The FDA is looking into it. And as of right now, and since the early 1970s, birth control is extremely safe. We know that, and people tolerate it really, really well.
Great.
And let me just say, risk of clotting in pregnancy and postpartum is much higher than with oral contraceptives. And again, we want to be comparing apples to apples. We're not comparing it to not taking birth control, because most people who take birth control want to prevent pregnancy, which does carry a higher baseline risk of getting a clot.
And Veronica, what are you seeing out there in social media? What kinds of questions are pharmacists asking? What kind of advice can you give to them as these questions are coming up for them in practice?
I think the biggest thing I saw on social media over the last week was the comparison that Jen just talked about of 1 in 1,000 women have blood clots, which is not correct, but they'll say, no one stopped birth control, but we're pausing the J&J vaccine. And that's where pharmacists, we need to step in and make sure we're not spreading that false information. And we're making sure that we're looking at primary sources. Where did this come from? And we're stepping in to say, this is not accurate. Thrombocytopenia is what we see with the J&J CVST cases. That's not what we see in women who are getting blood clots on contraception. And so making sure we're dispelling those myths, that's really important. And we're also seeing, vaccines can change the DNA of your fetus if you get it when you're pregnant. There's no truth to that at all. None whatsoever. And so that's explaining how messenger RNA works. And that is not getting into the DNA. It's not changing your genome in any shape or form. And so I think trying to stop and have really good conversations if you feel comfortable reaching out to people. I always say try not to get in the comment section of people's posts. Send a direct message to someone if you feel comfortable. Don't start those wars. I'm happy to share tips on how to have those conversations from a motivational interviewing perspective. I think my reaction as a medical provider is initially I want to debate and I want to prove that I'm right, and I have to rein that in and have a conversation with someone and come to it from a place of acceptance where I'm not trying to tear down somebody's whole sense of their world and rearrange what they know, but I'm trying to come at a place of understanding. But social media has not been great when it comes to dispelling vaccine myths, but it's a great opportunity as pharmacists to get in there and have really honest and open conversations. So I think the more positive messages you can share, the more primary sources of information you can share, and citing where you're getting your information is really important to try to teach your Facebook friends and Twitter friends where to find good information.
I love that. You've given some great advice. Definitely, we had a great webinar last time where we talked about myths and how to communicate some misinformation, address myths with some good language. But I love the comment you said on not getting into a war, but actually, messaging somebody privately. Hopefully that allows for a better conversation instead of going back and forth there. So I know both of you had some great resources, and I just wanted to point that out, that the handout has some great resources that ACOG has offered. And I don't know if you want to highlight any of these, Jen, and I know, Veronica, you also shared some really great resources. But Jen, I'll let you talk about this ACOG resource page.
So multiple times a week, we have the premier experts across the country in OBGYN, maternal fetal medicine, and fertility medicine coming together and reviewing all of the data. And what's really nice about this service is that all of our COVID-19 materials are open source, so they're not behind a paywall, so anyone can click on these links and receive this sort of synthesized information. We talk about primary sources, and that's really important. But those can be hard to sift through, especially when you're getting 10 of them in your inbox a day. And so ACOG is working very hard to collate those for you and create coherent and clear guidelines. So our practice advisory is constantly being updated for pregnant and lactating patients. That's that first link here. We also have a conversation guide for clinicians, which if you're in the moment or have a half an hour in between vaccine patients and you want to take a look at that and get some tips on how to talk about this, we definitely have those recommendations. And then all of these other resources that you see here are joint statements that we worked on with multiple organizations to try to ensure that we're capturing all of the possible opinions and viewpoints in terms of people who are pregnant and lactating. And I'm really proud of the work that ACOG has done. We've been a leader in this, especially when you think about the populations that we're talking about, which are often left out of these conversations. And so we've been leading that, and we hope that you will lean on our resources because we're really proud of them, and they're very high quality.
Oh, thank you. No, these are great. I know I'm going to go and look at some of these after our conversation here and see what I can subscribe to, because this is great information. Veronica, you had some slides or some resources that you wanted to share also, if you can speak about them a little bit here.
Definitely. I really like the Academy of Breastfeeding Medicine statement on considerations for COVID-19 vaccinations and lactation. I shared this with a lot of providers and patients that have a little bit higher health literacy level, just acknowledging that some patients might have fears about, oh, what is this vaccine going to do to my baby? The vaccine isn't going to get passed through breast milk as far as we know. And if it does, it's going to be broken down by the baby's digestive system. And so this reference I used quite a bit. I shared it a lot on social media throughout the time that we've had the vaccine, and that has alleviated some fears. It gives you some good talking points for talking to patients who are lactating. I also like a Mother to Baby, which is the Organization of Teratology Information Specialists. They have great resources on the COVID-19 vaccine and pregnancy. They also have a lot of good podcasts on pregnant and breastfeeding women if you want to listen on your commute in the car. It's a great listen to, very easy. They have nice handouts that you can print off to share with your staff. And then the American Society for Reproductive Medicine has some nice updates and resources that talk a lot about how do you discuss this with patients who are trying to conceive or who are using IVF. I know we've had some questions about that, but we do recommend that women who are seeking fertility treatments do get the COVID-19 vaccine when it's offered to them, which should be all adult Americans now.
Great. Wow. These are great resources. Thank you both for sharing them. And again, they're in the handout that's provided here in the link in the GoToMeeting toolbar. So what we'll do now is we'll go ahead and go into the open forum discussion to share your questions and thoughts. And a lot of these have already been hit upon, but there are a couple that I definitely want to go into. So if we go to the next slide, please. There it is. So let's talk about a little bit about some of the questions that are coming in here in the toolbar. One that keeps coming in, has come in a number of times, is the impact on women's menstrual cycles. There's been a couple of posts that I've seen out there about the impact on this and more people sharing their experience or information. Do you have any insight as to that impact, if there is one? Jen, we'll start with you.
So I think the first thing to note about this is these are anecdotal reports. There are millions and millions of people that have received the vaccine. And so it's not a trend that we have noticed has been happening. Some advice on how to talk about this, though. For example, I specialize in contraception, especially complex contraception. And there are a lot of side effects that people report anecdotally that aren't in the literature, are not trendable, but people report them. And so the way that I talk to patients about it is some people have experienced this. It's not something that we typically counsel about, but I want to make sure if you've expressed concern about mood disorder or heavy bleeding or spotting, that you know that this is a possibility, even though we don't have great data to suggest that. And so it's not really hedging as much as it's just discussing anecdotal data in the context in which we have received it, which is a couple of people. We don't think that it's actually causing this, but ultimately it's possible. And if you have one or two weird periods, everyone's entitled to a weird period in their life, is what I always say. And so that may be yours. And certainly I give them, precautions as well. If your periods continue to be heavy, if they are far heavier than what you expect them to be, it's likely not related to the vaccine. And I'd recommend that you go and see your physician to make sure there's not something else going on.
Great. And Veronica, do you give pharmacists advice on this topic, or just even the reporting with the VSafe? Like, that's one of the things I haven't seen as much. Hopefully we could do more so we can collect this type of information, but any guidance on that or recommendations?
I recommend that as pharmacists, we encourage our patients to report that if you're having weird periods or a heavy period than normal or a longer period than normal, and it's totally out of the ordinary for you, to report it to VSafe. I think the more information we have, the better. Knowledge is power, and we're still so new. Even with this pandemic a year in, we know a lot more than we did last year, but not as much as we will a year from now. And so I think the more we can report, the better. I think the most important thing is to piggyback what off Jen said, is to reaffirm the patient and make sure that they don't feel like they're not being listened to, that you listen to them and acknowledge their concerns. That is really, really crucial. So just because this is not widely reported in literature doesn't mean that it's not real. And I think that's what patients need to hear from pharmacists, especially if they're talking to you and they maybe not be established with a healthcare provider. That's a great opportunity for you as a pharmacist to help refer them to an OBGYN or a primary care physician, family medicine physician in your community if they're continuing to have menstrual cycle related issues. But you can look up where your nearest maybe Title 10 clinic is if they lack access to other funds, but get them connected with an OBGYN, I think, is key if they continue to report these symptoms to you.
Great. No, great. There's a question that came up. It's one of the earlier questions, but I definitely wanted to address it here because I think it's very pertinent. The question is there a recommendation on when to receive the COVID vaccine when going through IVF? And which vaccine is recommended for patients who has a higher risk of clotting due to a blood disorder? So sort of a combo question there. Any thoughts about that question?
As Veronica mentioned, ASRM, which is the Society for Reproductive Medicine and represents a lot of the folks who provide IVF for individuals, feel that it's safe to get the vaccine while you are seeking pregnancy as well as going through IVF. I certainly would recommend you having a conversation with your individual doctor about your individual situation. Everyone's health and situation is different. And so that's the caveat that I put to any recommendation, regardless of whether it's got decades of experience behind, decades of data behind it, or this sort of late breaking data that we have going on with the COVID-19 vaccine. But certainly it is not in any way, shape, or form a no-go. I would definitely seek the vaccine if it's something that you're interested in, as well as discuss with your IVF provider. And then in terms of the other one was the clotting disorders. No data right now to suggest that individuals with clotting disorders are at any higher risk with the Pfizer or Moderna vaccine. I think that if I had to gander a guess, that's probably why Johnson & Johnson was paused. They're looking at that right now, and so no one who has a clotting disorder can get the Johnson & Johnson vaccine, and we'll know a little bit more once the FDA and the ACIP meet and let us know what they're thinking about that. But certainly right now, no reason why an individual couldn't, in the United States, get Pfizer or Moderna with their clotting disorders.
Great. Anything you want to add with that, Veronica? Any comments or thoughts?
I completely agree. I think just kind of reassuring people that based off what we know now, I would get either vaccine that's offered to you, whatever is readily available in your area. And we'll continue to review the data as it comes out from the FDA and ACIP.
Great. And I see a few questions here around information related to immunity for a baby, either after breastfeeding or the duration of that. Any comments as it relates to breastfeeding and protection for a child?
I can take that. Data we've seen out of Israel shows that when they looked at breast milk, we saw the IgA and IgG antibodies were detected in breast milk up to 6 weeks is the length of time that they studied in breast milk. So that's what we know now. Hopefully it's longer, and we're not sure if, after if you stop breastfeeding, how long that immunity lasts. We're just not sure yet. We are anxious to get that data. I will encourage all of you to encourage your patients, your colleagues, family members, yourselves, if you are pregnant or breastfeeding, to consider enrolling yourself in some of the trials that are going out there that are collecting data. Some are just collecting data from pregnant and lactating women or those trying to conceive. So there's really not a lot of work to do on your end other than fill out surveys. I myself have done that. I'm really wanting to enroll in a survey that will take my breast milk samples here in Indiana, because I just really want to contribute to science and more information. But I think that's important, is telling our patients that these studies are out there, and it really, really helps if they can enroll, and it's such a low risk on their end, and it just helps us know more about the safety of the vaccines.
Absolutely. Any comments, Jen? I
think that was a perfect explanation. Just want to add on that it's, I think, important to emphasize the general immune benefit to the infant in breastfeeding. And so overall, we know that helps build immunity in general for kiddos. And so if breastfeeding is something that your patient feels like it makes sense for their life and for their family, which I always talk about, breastfeeding is really great, but it's also really, really hard to do. And so we don't want to shame anyone who's not breastfeeding, but certainly if they can be encouraged to breastfeed and reminded that it's great for their baby's immunity, regardless of whether we know about COVID-19, which it's, as Veronica mentioned, we are starting to learn more about that. Breastfeeding is great for immunity generally.
Great. And I saw a question here about, maybe you have comment. What can we do to push research sponsors to include pregnant women and breastfeeding subjects in more clinical trials? I think that comes up a lot, and it's obviously a very concerning population. But any comments around that? And I know we're collecting information now with VSafe, but any thoughts about that question?
I think engaging with your local professional organization or advocacy organization, if they are not currently advocating for this, helping them understand why it's important to advocate for. I think the collective voice saying we need to be including folks who are pregnant or breastfeeding in trials is what's going to move the needle on this. And so I like to say use the broken record method of advocacy, which is every time you hear about a trial, ask if pregnant people were included, and if they weren't, ask why. And that sort of will start keeping it in people's minds and let them know that we actually want that to be the case. A lot of folks think that they are excluded for some reason, that they shouldn't be in trials for some reason, and that's not the case. And so even just getting the message out there, I think, can be really helpful.
Great, thank you. How about you, Veronica? Any comments about that?
I think that's crucial. That was a perfect explanation, but I think letting your organizations know, I think letting lawmakers know is always a great way just to raise awareness of this, that women were excluded from trials for so many years and still are underrepresented, but continuing to get pregnant and breastfeeding women in trials, or lactating patients, I should say, is very, very important. So the more that you can do to raise awareness about this and talk about it, the better. Kind of use your everyday practice to advocate for this.
Great. And I see a question here around ingredients in the vaccine. This has been coming up quite a bit, but the question is, how can we address myths related to ingredients in the vaccine? I'm hearing that this is the first time polyethylene glycol is used in a vaccine, and concerns related to this. Any talking points that you want to give to address the ingredient concern, because that's been something that's been circulating quite a bit, and I'm not sure if this is just specific to pregnancy or just in general for anybody with this new ingredient. I don't even know if it's a new ingredient actually, but it's been used for vaccines. Any questions or concerns around that? And I'll start with you, Veronica.
I think it's a great question because there's been a lot of talk about this. There's been a lot of misinformation about PEG being in vaccines and what it is, and people, a lot of people that are of the anti-vaccine movement saying that it's a toxic chemical, and it's not. I will say I was very pleased to see the ingredients in the mRNA vaccines that came out, because it's a very clean list. It's a very simple list. A lot of things that we eat and drink every day have more chemicals than what's in the vaccine. And I think that's a good way to describe it to patients. Even if you follow a very clean, healthy diet, that just by ingesting fruit, you can get certain ingredients in your body as well. And so the vaccine, very easy to tolerate from a PEG perspective. So just making sure that patients don't have a reaction to that in the past is really important. But I think it's a novel concept, and it's exciting that we're trying to use different products and vaccines. And I'll let Jen add on what else she has for this.
I'll admit I am not a vaccine ingredient expert or a PEG expert, but I am an expert in speaking with patients about difficult subjects. And so I would say that folks probably fall into a couple of different buckets who are raising this concern. There are people who are vehemently anti-vaccine, and those folks are probably not going to be convinced by our conversation around this, and not necessarily at your pharmacy office or wherever you are having this conversation, certainly not in a Facebook comment. Then there are the people who are hearing this and genuinely concerned about their friends and their family, and are not understanding this and are hearing the word chemical and being worried about that. And so I try to evaluate where they are in their understanding and how much they're interested in trying to understand and learn. Sometimes people just are needing to be heard about their concerns, and I think that's really reasonable to do. I often talk about how the word chemical is maligned. Water is a chemical, and so we often talk about ingredients in a way that is a little bit misleading. And certainly, if somebody is really hesitant about the vaccine, as much as we're trying to get people to get the vaccine, it is an emergency use authorization. We still don't have a ton of the data. And if so, they're really nervous about it, I am not going to push them into any direction that they're not comfortable with. I will talk to them about other ways in which they can keep themselves safe from COVID-19, which include social distancing, quarantining themselves, trying not to travel, continuing to use face masks, all of those things that we used before the vaccine. And so I just want to make sure that we're being clear that we don't want to force anyone who's unsure about this vaccine, because it is emergency use. I mean, we shouldn't force anyone ever, but it is reasonable to be questioning this, I think. And there has been a little bit of a tension between the scientific community and then all of these myths that we get annoyed with them, which I'm guilty of. but it is coming, I think, from a place of real concern for their families and people that they care about. And so I try to do the best that I can to have empathy for those viewpoints. And I certainly don't know very much about PEG, but I'm going to trust people like Veronica and the scientists and what they're telling me.
Oh, I see them.
I just have one thing about polyethylene glycol. Polyethylene glycol is a common ingredient in a lot of different injectable medications. And so very appropriate for today's discussion, one of those is medroxyprogesterone acetate, includes PEG. And so a lot of patients receive that. Another common medication which includes PEG is local anesthetics. So that may be another way to help alleviate your patient's concern. I mean, we use local anesthetics all the time. Lots and lots of patients are getting medroxyprogesterone. So one other fact for your armamentarium there.
Well, thanks for sharing that, Dan. I was like, yeah, PEG, I'm surprised that it hasn't been used, and you just confirmed that it is being used in other things. I didn't think it was the first time we would uniquely use this, and but thank you for sharing. Now you've given us some very concrete examples that we can share with patients, so appreciate you stepping in for that. And there's a great question here, Jen, it's to the ACOG questions. Are there any differences between ACOG and CDC recommendations for vaccination of any differences in those, or are they being those?
Can you repeat that? I'm sorry, I think it cut off a little bit for me.
The question is there any difference between the ACOG recommendations and CDC recommendations vaccinating pregnant women?
No, there's not. We work very closely with the CDC on a regular basis, and so definitely no difference.
Okay, great. Let's see, I'm just trying to go through and answer some of these questions around an individual who was pregnant and received the J&J vaccine, and just information around some of the things that you discussed. How can you contribute to science? People find out about trials or surveys or studies that they can be contributing to as it relates to information that they're getting.
One essay I like to recommend patients to, it's actually one of the references, but it's linked to the COVID-19 references. Mother to Baby, the Organization of Teratology Information Specialists, keeps a list of trials that are enrolling patients, and you can submit an interest form and they will help connect you with trials that are going on. Sometimes your state may have a trial. So in Indiana, I'm really lucky that all of our kind of health systems work together in our universities to do related research. And so you can sign up as a participant. We have it called All In for Health is what we sign up for. And so looking around that in your state, that can be really helpful. And talking to your OBGYN is another great way, is they may know what's going on locally, any local enrollments, and also those that might be connected with some of their national organizations or state associations.
Perfect, thank you. That's great. Good, good references to look up additional trials. I'm always interested in participating in things like that, so that's a great resource. This is a great question, and I had not seen it come up before, but it is a very good question. Is there a preference for trimesters for when people should get vaccinated against the COVID vaccine? Any recommendations that are out there, and either one, if whoever wants to jump in.
Whenever you can get it, get it. If you're first, second trimester, third trimester, whenever you're able to get the vaccine, go ahead and get the vaccine. There is no recommendation that one is better than the other at this point.
Great, thank you. Yeah, so this is a question that comes up a lot, so that's a thank you for saying that. Just a couple of more questions coming out around J&J vaccine. So no concerns that you have around pregnant women as it compares to other vaccines, no preference. The first one first, I know you've mentioned that before. Any other comment related to that?
Prior to the pause, we were not recommending one over the other. I think we're waiting to see what comes out of the pause and the investigation that ACIP and the FDA are doing. And so I think we need to wait until we hear from them, and we will then evaluate that data and those expert recommendations and change. We will change, and as we have been doing, any new data, kind of synthesize it, bring it in, and if we need to make a change in recommendations, we will. But prior to the pause, we were not recommending one vaccine over the other.
And I think you can reassure patients that have gotten the J&J vaccine and tell them, continue to report any symptoms that you have to be safe. Talk to your healthcare provider if you are worried, but tell them not to be alarmed by what's happened. what this means is our system is working well, right? That we put a pause, we wanted to investigate the J&J vaccine. There's no causality that's been determined for CVST. So the system is working well. And so I think it's important to reassure our fellow healthcare workers that have received the J&J vaccine as well as our patients.
Well, with that, I think we're going to stop here, and I just can't thank you both enough for joining us today, for answering some great questions that people have had out there, pharmacists and other providers too. So I, again, can't thank you enough for all the work that you're doing to educate us, educate the public, and all the work that you just do on a day-to-day. So thank you so much for joining us. What we're going to do next is we're going to go over and talk a little bit about what's going on with APHA. There's a lot of things that are coming out. So thank you, Jen. Thank you, Veronica, and hopefully we talk to you soon. But I'll invite Elisa Bernstein up on the stage here to talk a little bit about the ongoing activities and what's going on.
Great, thanks so much. Yeah, really busy time here in our nation's capital. Some really good news we expect to hear very soon, and we expect to hear that pharmacy's Keystone Provider Status legislation will be introduced in Congress soon. That's what we expect. So this is the legislation for the Pharmacy and Medically Underserved Area Enhancement Act, which has been introduced in the past. It's the legislation that would allow pharmacists in medically underserved areas to bill Medicare Part B for patient care services, limited to the scope of practice. We're waiting on pins and needles for it to be introduced, so stay tuned. As soon as it is, you'll hear from APHA. We'll send you an email. We'll provide opportunities for you to easily reach out to your legislators to ask them to support the bill. So really excited about this. But again, we're waiting to hear when it will happen. So stay tuned. Let's go to the next slide, because there's a lot of really good information and some other wins as well coming out of the regulatory agencies. So this is something we've reported on before. So the government has a program that provides compensation to patients who are injured from vaccines. And if the injury is on a vaccine injury table, it's called an injury table, the patient is compensated from a government fund. If it isn't on the table, so if that injury isn't on the table, then the immunizer, pharmacists and others, can be liable for that injury. The previous administration proposed to take shoulder injuries and syncope off of the vaccine injury table, which would open the door for pharmacists and other vaccinators to be sued if these injuries occur. So through advocacy from APHA and NASPA, we sent numerous letters to the administration urging them to keep shoulder injury and syncope on the table. And among other things, we said that making such a change during a pandemic when immunization is so essential just doesn't make sense. So this week, the administration officially withdrew the regulation that would have taken these injuries off the table. Yay. And that's a major win for pharmacists, and it preserves the patient's ability to get compensated. So that's really great news for us. Also, also out of HRSA, the Health Resources and Services Administration, we can go to the next slide. We've been hearing from a number of members about concerns and problems that they've had with getting reimbursement for vaccine administration for uninsured patients. So HRSA has a program specifically for that you can apply to and get reimbursed for those vaccine administration services for uninsured patients. But it's been very difficult, it's very complicated. APHA has met with HRSA and the United Healthcare representatives. So United Healthcare is the organization that administers the claims and processes these claims for testing, COVID testing, treatment, and vaccines for HRSA. So we sat down with them a couple times, but last week we had a really great meetings with them where we walk through the concerns and they walk through the process with us. And we will be very shortly releasing an issue brief with more information, but basically This program is billed through the medical benefit, like medical claims for medical beneficiaries. So we as pharmacists, we're used to mostly on the pharmacy side. So this goes through the medical benefit. And what they did is they told us about how to go through, what are some tips and tricks. For instance, one of the things that wasn't clear is that you can apply and you can put in for claims going back for the last 12 months. So even if you didn't submit them. So stay tuned. We will be sending out information in a really easy to understand, concise way in one of our issue briefs very shortly. And so, but we just wanted to preview that today. We can go to the next slide, please. So here is a reminder of our amazing Know the Facts practice resources, or issue briefs is another term that we use. This is an amazing database of resources that are constantly being updated by APHA staff. In the coming week or weeks, you could expect to see the one about the uninsured patients, focusing one on updating our monoclonal antibody resource, as well as updating our resource related to fraudulent and counterfeit COVID products, because we are hearing reports, and FDA has heard and shared with us reports of not just counterfeit vaccines, but also the vials being used, discarded vials being used for counterfeit. So we're going to be updating some information there as well. So I think that's it for me, and I'll turn it back to you, Sandra.
Thank you, Elisa. I mean, it's incredible work that you're doing to advocate for the profession, what APHA is doing to advocate for the profession. These are examples, you know, really talking about provider status again is wonderful, talking about advocacy for making sure pharmacists are protected as they're trying to do the right thing, and then making sure there's sustainability with the billing concern. So thank you for sharing that. And then the practice resources are wonderful. I know a lot of people have been referencing those. So thanks for all the work that all APHA staff is doing on behalf of pharmacy. So let me just go through and just remind you that we had a really great presentation a couple of weeks ago on COVID-19 myths and facts, vaccine that's now available for CE. Please go to the APHA library for that CPE, and there's some really great talking points that were discussed on today's webinar, but on last webinar too, that can really help with practice there. This webinar is available, and this one that we're dealing with today will be available in 24 hours also. So these will be listed as links there in the education library. So next slide, please. We are also really encouraging you as attendees to continue the conversations in the Engage platform. Really, whatever you can share, whatever you can post to support each other and to access the latest information, to really talk about what are the latest concerns you're hearing with the COVID vaccines, what resources you want to share, because that really helps us build the webinars for future broadcasts. So anything that you can do with Engage will be very helpful to us as we're trying to build more education and programming around that. So hopefully we'll see you on Engage. And for the next webinar will actually be on Thursday, May 13th. We've moved to a webinar series that's the second and the fourth weeks of every month. We will figure out the topic as we're working on what's most critical then, but just remember that there is CPE available in the May webinars. We're going to have 2 of them, and registration information will come out very soon. Today's webinar, again, will be available in 24 hours, and please make sure that you pick up that handout that's on the GoToWebinar toolbar. In that handout, you will find some additional slides that were provided by ACOG, and some of the resources that Veronica provided were wonderful. And we can't thank the speakers enough again for all of their information today. And we really want to thank ACOG for partnering with us on this wonderful webinar. Hopefully the information that you found today will help you in your practice. So thank you so much for joining us. We are excited that you're leaning into this COVID pandemic, and hopefully we'll be over it soon so we can see each other in person. Thank you so much. Have a great rest of the week.